Assalamu alaikum, good morning. My name is Dr. Hawra, and today I'll be presenting celiac disease. I'll be presenting updates about celiac disease. صوت okay? برفع صوتي شوي. برفع صوتي. لا ما اشتغل. Okay, I'll raise my voice a little bit. Yeah, okay. So celiac disease is a chronic small intestinal immune-mediated enteropathy. It is precipitated by exposure to gluten in our diet in genetically predisposed individuals. And the gluten is present in wheats like barley, wheat, rye, and tretkai. Oat doesn't have gluten. The prevalence of celiac disease is around 1%, and it can manifest with both GI and non-GI manifestations. Celiac disease may remain undiagnosed for years and even decades, and it's a common cause of malabsorption of vitamins such as vitamin D and key nutrients like iron. So celiac disease is strongly genetically determined. Around 90 to 95% of patients, they carry the HLA DQ2.5 heterodimer, which is encoded by these two alleles. And the remaining 5 to 10% carry the HLA DQ8 or DQ2.2. So if these two genes are not present, celiac disease is very unlikely. So in a patient who has a strong genetic background with some environmental factors or triggers like gluten exposure, which is of course the essential part of the pathophysiology, as a loss of gluten tolerance, which can occur at any time during age, GI infections, some medications like alpha interferon, or for example, repeated antibiotic exposure in children have been implicated as trigger factor, surgery or any stress, in addition to disrupted gut microbiome. So in the presence of genetic predisposition and environmental factors, celiac disease can be triggered. Moving on to the pathophysiology of celiac disease. So first, when the patient ingests gluten in his diet, this gluten is broken down into smaller peptides, which is gliadin. And gliadin is then transmits the cell membrane into the lamina propria, where it gets interacted with tissue transglutaminase. This tissue transglutaminase converts the gliadin into deaminated gliadin peptide, which is the DGP. And this DGP is then taken up by the antigen-presenting cells, and they present it to CD4 T cells. CD4 T cells gets differentiated into activated T cells, therefore producing the cytokines, which is interferon gamma, interferon 2, and interleukin 2 and interleukin 21. They also produce B cells. B cells then differentiate to plasma cells, and plasma cells, they secrete IgA. This IgA is the one that we measure in the serum to test for celiac disease. So finally, the inflammatory response leads to an increase in intraepithelial lymphocytes, and they have natural killer activity, leading to the destruction of the inflammatory response and the destruction of the enterocytes and the cascade of events in celiac disease. So the risk of celiac disease among first-degree family members can reach up to 10 to 20%. And among patients with other autoimmune diseases, for example, in type 1 diabetes, it can be up to 12%, thyroid disease up to 7%, and liver disease up to 5%. So it's important to test these patients. Clinical manifestations, as we said, GI and non-GI. So the classic GI manifestations are nausea, vomiting, abdominal pain, bloating, chronic diarrhea, malabsorption, and in children, failure and stunted growth. Non-GI manifestations, they're actually wide, and it's important to know some of the clinical features. For example, neuropsychiatric symptoms may have peripheral neuropathy, cerebellar ataxia, migraine, seizures. Reproductive system, it is important to test for celiac in patients who have delayed menarche, unexplained male or female infertility. Certain skin lesions like dermatitis herpetiformis, which is very specific for celiac disease. Recurrent aphthous ulcers, alopecia. Patients with deranged liver enzymes as well, we have to test them for celiac disease. Some malignancies are associated with celiac disease, which although they are rare, but they are associated. For example, the enteropathy-associated T-cell lymphoma, which is associated more with refractory celiac disease, adenocarcinoma of the small intestine, head and neck cancer, and interestingly, esophageal cancer. So who should be tested for celiac disease? So if the clinician has a suspicion of celiac disease in a patient who has clinical manifestations of celiac disease or patients with dermatitis herpetiformis, they should be tested definitely. So this box shows us the group of patients who should be tested: persistent unexplained abdominal or GI symptoms, prolonged fatigue, unexpected weight loss, severe or persistent mouth ulcers, unexplained iron, B12, or folate deficiency. So this box, it's recommended to test for celiac in these patients. And here it is consider testing for these patients. For example, unexplained neurological symptoms, dental enamel defects, persistently raised liver enzymes, unexplained subfertility or recurrent miscarriage, and finally, metabolic bone disorders. So do we screen for celiac disease? In the general population, there is no screening program. However, screening should be done in high-risk groups. And these high-risk groups, for example, like we mentioned earlier, first-degree relatives, certain autoimmune conditions, and other conditions that may mimic celiac disease, like IBS, IBD, microscopic colitis. And finally, when other conditions have evidence suggests a high prevalence of celiac disease. For example, patients with Down syndrome, Turner syndrome. So they are at increased risk of developing celiac disease, so we have to test them in these patients. So how to make a diagnosis of celiac disease? First of all, the patient has to be on a gluten-containing diet. And this is defined by at least 3 to 6 grams of gluten for at least 6 weeks. That if the patient had already stopped a gluten in his diet, we have to reintroduce it. Then we check the celiac serology, and the main test that we use is the IgA-TTG. It's the first-line investigation, and you have to combine it with total IgA levels. And if the serology is positive, we have to confirm with duodenal biopsies. Now, why we test for IgA deficiency? Because selective IgA deficiency is a common primary immunodeficiency which leads to low serum total IgA levels. This condition affects around 1 in 500 to 700 individuals, and these individuals have a risk of getting false negative IgA serology results. And due to genetic susceptibility, around 6% of these patients may have celiac disease, and 2% of patients with celiac disease have selective IgA deficiency. Therefore, we do it by a simple one-time measurement of total IgA level in the blood. And if selective IgA deficiency is present, we have to measure the IgG-based serology, for example, IgG-TTG instead of IgA-TTG. So if serology is positive, we move on to endoscopy and taking duodenal biopsies. And it's important to note that celiac disease is a patchy disease. Therefore, we have to take multiple biopsies from both D1 and D2. And the number recommended so far is 2 biopsies from D1 and 4 biopsies from D2, because they have found from many studies done in the UK and the US that taking 4 biopsies from D2 increased the yield and the diagnostic rate of celiac disease significantly. For GI, it is important to do the single bite biopsy technique, i.e. we don't take 2 biopsies with the same biopsy forceps because it can crush the sample. And it is recommended to use a standardized histological grading system. The most commonly used are the Marsh, Corazza, and the Vilanci systems. We usually use the Marsh system. And this is the Marsh classification, which shows us the histological features of celiac disease. So Marsh 0, we have normal villi and normal crypts with no increase in intraepithelial lymphocytes. In Marsh 1, we start to see more these blue dots, increase in intraepithelial lymphocytes. In Marsh 2, the crypts become hyperplastic. And in Marsh 3, if you see the finger-like projections are no longer apparent in Marsh 3 because the villi are atrophic. And see here, there's complete atrophy of the villi. Do we use the HLA typing in diagnosis? The question is no, it's not used in the initial diagnosis. However, it can be used to rule out celiac disease in selected patients because it has a high negative predictive value. So we use it in patients who have negative serology and they have MARSH 1 and 2. So not very definitive histology for celiac. We use it in patients who have already started on a gluten-free diet and they don't want to restart a gluten for a gluten challenge in their diet. And finally, when there's discrepancy between the serology and the biopsy. So how to make a diagnosis of celiac disease? So we have the standard serology biopsy pathway in which you can make a diagnosis of celiac disease using positive celiac serology, in addition to positive histology, which is duodenal biopsies demonstrating increased intraepithelial lymphocytes more than 25 per 100. With crypt hyperplasia, either with or without villus atrophy, i.e. MARSH 2 and 3. The new thing here is the no biopsy pathway. The no biopsy pathway was previously implemented in children. However, it is recently expanded to adult guidelines as well. However, the prerequisite is that you need to have a total IgA-TTG titer more than 10 times the upper limit of normal, which is very high. And this high level has very high sensitivity and specificity for celiac disease. Therefore, in patients who are symptomatic, in the secondary care setting, and only after shared decision-making, you can make a diagnosis of celiac disease without biopsy, only in patients having an IgA-TTG titer more than 10 times the upper limit of normal. Other possible scenarios is having potential celiac disease. Potential celiac disease, you check the serology, it's positive, but you do the biopsy and it's not MARSH 2 or 3, it's MARSH 0 and 1. You do the HLA and it is positive. So these patients are named potential celiac disease. We manage them as celiac disease, we start them on gluten-free diet, and we monitor the response. Seronegative celiac disease is when you have normal serology. However, the biopsy is very consistent with celiac disease. It shows MARSH 3. These patients have positive HLA typing and they improve on a gluten-free diet. So we label them as seronegative. However, we don't label them as seronegative celiac disease unless we rule out other causes of villus atrophy, like the one in this table. So this table shows us the causes of increased intraepithelial lymphocytes without villus atrophy, for example, in infections like H. pylori, giardiasis, drugs like nonsteroidals and PPIs, other conditions like Crohn's disease, microscopic colitis, common variable immunodeficiency, and graft versus host disease. These are the conditions in which we see increased intraepithelial lymphocytes and villus atrophy. Again, giardia, Whipple disease, TB, medications like nonsteroidals, MMF, and so on. So how do we manage patients with celiac disease? The only accepted management so far is a lifelong gluten-free diet with support of a dietitian. Gluten-free diet will improve symptoms within weeks. However, mucosal healing may take up to 1 to 2 years. Gluten-free diet improves symptoms, improves quality of life in these patients, reduces the risk of complications like osteoporosis and lymphoproliferative malignancies. Persistent symptoms, despite on a gluten-free diet, may indicate non-adherence or other complications of celiac disease. So how do we monitor adherence to a gluten-free diet? First, we have the dietary assessment. The simplest method is that we ask the patient to fill in a questionnaire. It's a validated tool to assess self-reported compliance and understanding of the gluten-free diet. This is simple and widely available. However, it's not reliable and may miss inadvertent gluten exposure. Inadvertent gluten exposure means that patients are unaware that they are taking gluten in their diet, maybe because of cross-contamination from, for example, bakeries or sharing utensils at home. Then we check their celiac serology because this reflects the ongoing immune response to gluten. So serology is available, and we have to recheck serology after the patient is instituted on a gluten-free diet. We have these tests for gluten immunogenic peptide, which is either done in stool or urine, and these reflect recent gluten exposure. So when available, you can use them to measure compliance. The other biomarkers like the IFAP, which is intestinal fatty acid binding protein. This reflects the recent enterocyte injury and correlates with villus atrophy. However, it's still investigational and not recommended routinely in the guidelines. Finally, the gold standard remains the duodenal biopsy. So when a patient is diagnosed with celiac disease, we have to follow them at 3 to 6 months. We check their serology, we check their hematological markers, check their CBC, check their nutrients, and then we have to also check their serology. If their serology is, if there are improvement, yes, so we have to follow them after 1 year. And some also recommend repeating duodenal endoscopy and duodenal biopsy to check for mucosal healing. It's also recommended to do a DEXA scan even after 1 year to make sure that these patients are not having osteoporosis and to support them with calcium and vitamin D if required. Now, if the serology is still negative and the biopsy is still abnormal, we have to rule out, we have to first make sure that this is the correct diagnosis. Is it celiac or not? So go back to the biopsy, go back to the serology and check. Make sure the patient is compliant to gluten-free diet. Reconsult the dietitian. Rule out other causes of other diseases that might cause villus atrophy or increase intraepithelial lymphocytes. Finally, I'm going to talk a little bit about other gluten-related disorders other than celiac disease. So we have wheat allergy. Wheat allergy, it's just like any type of allergy, it's an immune reaction to proteins found in wheat. So when a patient ingests wheat, they develop rapid onset symptoms, which is within minutes to hours, like anaphylaxis, urticaria, or respiratory symptoms. These patients, they have positive wheat-specific IgE testing, for example, skin prick or the serum IgE. The other condition is non-celiac wheat sensitivity. This condition is characterized by IBS-like symptoms and extra-intestinal manifestations of celiac. It occurs after ingestion of gluten-containing food. It improves rapidly when gluten is eliminated from the diet, and the symptoms come back when gluten is reintroduced. However, we don't make the diagnosis of non-celiac wheat sensitivity until we rule out celiac disease and we rule out wheat allergy and we rule out major GI disorders. It's still a gray zone, and not many guidelines have recommendations for non-celiac wheat sensitivity, but it's there, and we don't even know the actual prevalence of this condition. But it's there. Think of it and test for it. Just to take home message, so celiac disease is very common. We have to think for it in order to test for it. And the testing, as I mentioned, starts with a simple serology, a tissue transglutaminase IgA, in addition to total IgA level. It is important to combine them at the same time. And if positive, send them for endoscopy and biopsy. Thank you. These are my references.